Thank you for this invitation. People are always so generous when I come to Kuwait, and I'm very thankful to you. Now, I'm starting with this very famous painting that hangs in the London Gallery of Copernicus. At the time, you know, he was thinking that it turns out that the Earth was not the center of the universe, but that the Earth was rotating around the sun. So that was his idea. The problem was that everybody else in the world thought the opposite. They thought that the Earth was the center of the universe and the sun was rotating around the Earth. And I really think we're at a similar position now when we are thinking about the disease of obesity, and specifically when we think about how we use nutritional therapies to treat the disease of type 2 diabetes. Now, these are my conflicts of interest, and we work with lots of different companies, with pharmaceutical companies, with nutrition companies, and also with surgical companies, because we don't think that obesity is one disease. We think there's lots of different diseases, and therefore we need lots of different treatments. So I think we need more nutritional therapies, I think we need more pharmacotherapies, and we need more surgical therapies. And I think this program is beautifully set up to show you that these treatments are not in competition with each other. These treatments are different treatments for different diseases. And at the moment, we are just not smart enough to know what these diseases are, but we will be very soon. But what I'm showing on the side here is this is our character. Let me just go back one step. So here we have Sisyphus. He's our Greek character that's been thrown into the depths of Hades, of hell. And what he had to do was roll up this rock, up this hill every day. And every day he got to the top of the hill, what happened is the rock rolled down. Okay? And he had to start this process over again. And I think this reminds me of what I did as a doctor when I gave nutritional therapies to patients who had obesity. I asked people to eat less and to move more. And I now know that that was wrong. Okay? Because every time when they ate less and they moved more, that was like rolling that rock up the hill. But every time they got to the top of the hill when they lost weight, the rock would roll down. And they would start all over again. Okay? So what we do as good healthcare professionals, if the data changes, we change our minds. And it is okay for us to change our minds. It's not a bad thing, because that's what we call progress. But a lot of the rest of the talk, I'm going to challenge you in the audience, and some of the things I may say may be a little bit uncomfortable. And that's not because I'm not grateful to your hospitality. I don't mean to be offending you, but I do mean to challenge you to think about what we are doing and whether or not what we are doing is the right thing. Because the problem is, here's another painting that hangs in the London Gallery of how scientists in 100 years ago in the Victorian ages, and today, of course, we have the coronation of the new king. So this goes back to Queen Victoria's time, several monarchs ago, and how that influenced people's thinking. And what you will see is the mad scientist in the middle, but you can see how society is reacting to the science. So you can maybe see the people at the front here thinking deeply about this problem. That's maybe Dr. Ebo working at the DDI. You know, she's thinking deeply about this problem. But you can also see for example, the lady on the left. You know, she is not interested in this science. And you can see the young girl on the right. She's frightened about this new science. And that's exactly what is happening today when we are talking about the disease of obesity and how we treat the disease of obesity to change diabetes. And you will see some people in society are really frightened about this idea that we're going to medicalize obesity, that we're going to medicalize nutritional therapies, and we're not going to just ask people to be better citizens. We are genuinely going to treat this as we treat any other disease. Okay? And therefore, many of the things that I have done in the past, when I look back, you know, I now recognize that that was wrong. Okay? And, you know, that now we need to do better. And here I will show you some of the things that we did that we thought was the right thing, but turned out to be wrong. So this is the classical experiment called The Biggest Loser, and it played out on television screens all over the world. You know, this is the US version, but it was in Europe. I'm sure you had a similar version over here. And effectively what they did is they took people with obesity, and some of them also had diabetes, and they made them dress up in funny clothes, and they made them run around doing exercise, and they shouted at them, and they made them do strange diets, right? And then they did that for a period of 30 weeks, and they saw who lost the most weight. But what the scientists did is they went back and looked at the same people 6 years later. And what you would see on the left-hand side first in those graphs is that people were able to lose weight. They were able to lose weight, and then after 6 years, they regained the weight. But look now at the middle panel. So here you see the resting metabolic rate. And what you would see is when patients lost weight, their resting metabolic rate came down, but when they regained the weight, the resting metabolic rate did not recover. And on the far right-hand side, you see the so-called metabolic adaptation. And what that shows is that what we did by making people exercise and making people diet is we harmed the patients. We created a deficit when it comes to metabolic adaptation. And you will remember that the first rule in medicine is do no harm. And what we've done here in retrospect is I think we have harmed our patients. And the reason is because this was not a nutritional therapy. This was a calorie restrictive therapy. And we need to differentiate those two. There's a very big difference between creating a calorie deficit and giving a nutritional therapy. And when we now look at that in essence, we have a person with diabetes and obesity. If you give them a calorie restriction, what will happen is, yes, they will lose adipocytes, they will lose fat mass. But the harm that you have created is you've created an energy gap. Because those patients become hungry, and they become hungry because of physiological changes. I'm showing you some gut hormone changes, but you also have reduced energy expenditure. So you have harmed them in two ways. So this is what we should not be doing. This is a calorie restrictive approach, which I think the science now shows us is the wrong way to go. So what is the opposite of that? What is a nutritional therapy for the treatment of people with obesity and diabetes? So here we are thinking about the way that your body and my body regulates certain masses of cells. So say, for example, we think about your red blood cell mass. You all live at sea level, so therefore your body regulates how many red blood cells you have at this moment in time. And it's a complicated physiological system. You use erythropoietin, you use your spleen, you use your bone marrow, and that is a physiological system that regulates how many red blood cells you carry. But if I take you and I put you in a different environment, say for example I move you to Switzerland, I move you to a village that's 2,000 meters above sea level, your environment change. And there's environmental pressures, for example less oxygen, that will change the physiology, and your body will regulate your red blood cell mass in a different way. Now your body will increase your red blood cell mass. And that is the same what is happening in many of our environments, because the environment is changing how our body regulates the amount of adipocytes that we carry. And so, for example, you could have a bad diet, you could maybe not exercise enough, you may not sleep very well, you may be very stressed, and that increases the point where your body regulates your adipocyte mass. And what we are suggesting is that if I take you from that village in Switzerland at 2,000 meters and I bring you back to Kuwait City, what will happen is your red blood cell mass will come back to exactly the same point that it is now. Okay? Because the physiological changes has happened, so we've changed the environment. And that is what we are suggesting when we are talking about nutritional therapies. We're talking here about a healthy diet, regular exercise, better sleep, reductions in stress, not to create a calorie deficit, but to change the environment that your body is in that regulates the number of adipocytes that we have. But I would suggest to you, as you know very well, that not everybody responds to this therapy. And we're going to talk about pharmacotherapies and surgical therapies, and even when we have the best therapies that we have, we will also see that we have responders and non-responders. But we do have responders to this approach, but in our hands, it's about 2 in every 10 people that will respond to this approach. We will also hear later from Alex Miras about medications that can do the same thing, and we'll hear from Jaltrudi Mangroni about surgery doing the same thing. So what I'm leaving you with is that nutritional therapies do not create a calorie deficit. Pharmacotherapy do not create a calorie deficit, and surgery does not create a calorie deficit. Nutritional therapies, pharmacotherapies, and surgical therapies treat the disease of obesity. And if you treat the disease of obesity, what happens is the level of adipocytes that your body wants to carry changes. The reason why that is an important concept is if we go back to the origins of the word obesity, the Latin here, and Jaltrudi will correct me if I have any of the Latin wrong, but it effectively means, the word means made fat as a result of eating. And if you think that is true, and I thought that was true a year ago, right? I've changed my mind now, but a year ago I thought this was true. I thought if you eat too much, you will become fat. That was the concept of obesity. And if you think that is true, then it is very reasonable for you to try to make people eat less, because you think that is the origin of the problem. What we are learning now is that the opposite is true. So I'm bringing you back to what Copernicus said. Remember, everybody in the world thought the Earth was the center of the universe and the sun rotated around it. But what Copernicus said, the opposite was true. The sun was the center, and the earth rotated around that. I'm bringing you back to that because it's reasonable for you to think at the moment that overeating causes obesity, but I'm going to ask you to consider the idea that, in fact, obesity as a disease causes people to overeat. And if we treat the disease of obesity with nutritional therapies, with pharmacotherapies, or surgical therapies, what we see happens is people eat less. They don't eat less because they're trying to eat less. They eat less because the disease of obesity is treated. Okay? But when we think today we're specifically focusing on people with type 2 diabetes, what we do not understand, and I don't think anybody in the world understands this really, but we do not understand why people with type 2 diabetes lose less weight when we give them a nutritional therapy or a pharmacotherapy or a surgical therapy in comparison to people that don't have type 2 diabetes. I'm listing some potential reasons that people have postulated, but really this is a very important thing that we need to understand, we need to research, because we don't have that understanding at the moment. But it is true. It doesn't matter. So, for example, you may have seen there was a press release last week about an amazing new treatment, tirzepatide, that you will have in Kuwait much earlier than we would have in Europe. You're going to have it in a couple of weeks or months. And this treatment, for people with type 2 diabetes, results in about 15% weight loss. But people that don't have type 2 diabetes, it results in 22% weight loss. So even our best treatments, there is a differential between people with type 2 diabetes or people that don't have type 2 diabetes. So I think that is very, very interesting. So we are setting this talk up because we want to use nutritional therapies, pharmacotherapies, and surgical therapies to disrupt the disease of diabetes. So let's think about everybody in Kuwait that has obesity. And we now superimpose everybody in Kuwait that has type 2 diabetes. Now what you will see is we have focused correctly In the last 10 years, we have shifted away from glycemia as the target for type 2 diabetes, and we shifted to prevent cardiovascular disease. And that's been very successful. So there's been a cardiovascular focus, but of course, there's an overlap of people. We can also see there's lots of people highlighted, as I have done just now, where this overlap occurs, but there's another group of people on the far right where we may have a glucocentric view, meaning, these people do not have obesity, they have type 2 diabetes, they do not have cardiovascular disease, and it is correct for us to focus, on their glucose. We should have a glucocentric view in those patients. Now, there's also a cardiocentric view, and that's what's been driven by the ADA and the EASD, and that is correct what we're doing in clinics now. And that's been a massive step, and that's helped our patients with type 2 diabetes. But what we are proposing right now is that when you see people with type 2 diabetes, you also need to think about having a weight-centric view, because we can disrupt the disease of type 2 diabetes in a large number of patients, as illustrated by that overlap, who have diabetes, who have obesity, and who may, also have some of the other challenges that comes with obesity. Some of the best data in this field comes from this region. And here I'm showing you the Diadem-1 study from Shara Tauriri, I'm mispronouncing his surname now, but showing that we can use nutritional therapies to treat people with obesity and type 2 diabetes. And that if we do so, we can put type 2 diabetes into remission. But I will remind you that with this study and others like this, the number of people who respond to this treatment is about 2 in 10 people. That means 8 in 10 people do not respond to this treatment. That does not mean that those 8 in 10 people are bad citizens or that they're not trying hard enough. It just means that they have a disease of obesity that is not responding to this therapy. But the opposite is also true, and here I'm showing you the data that was replicated, what we've already seen from Mike Lean and his group, in the UK, showing that again with 15 kilogram weight loss, more than 80% of patients with type 2 diabetes and obesity goes into remission. Again, similar numbers. Only 2 in 10 people responded. So what I'm taking from this is, first of all, that nutritional therapies do work. They are very safe, they are very effective, but they are effective in 2 in 10 people. But when it works, we should continue with it. Okay? So it means we should have more nutritional therapies because it's so safe and it's so effective. But if people do not respond to them, then we need to change. It's no point in beating people with sticks and making them run around and wear funny clothes, right? It is about, thinking about this as a disease where there's responders and non-responders, and if people don't respond to our nutritional therapies, then we can move on. Here I'm showing you the Step 2 study that Alex Miras is going to talk a little bit later about. And he's going to talk about the pharmacotherapy, but what I want to focus on here is I want to focus on the placebo arm. The placebo arm is the line at the top where patients lost about 2.5 kilograms of their weight. But you will see on the right-hand side, there was even people with the placebo arm, which effectively had placebo plus nutritional therapy and exercise therapy. There was about 5% of them who lost 20% of their weight. Right? So it does mean, I misspoke. It's about 1.2% of people who lost 20% of their weight, and again 2% of people who lost 15% of their weight, and about 7% of patients who lost 10% of their weight. Okay? So those are nutritional therapies that worked for those patients in the placebo arm. Okay? So it does work, but it works in small numbers. But look what happens, to those patients that do respond. So I'm focusing you, again, this is the Step 2 study, and maybe Alex is going to focus on the medication arm. I want to focus on the placebo arm. So the placebo arm is on the left. And you can see before patients were treated with placebo, you could see about 57% had normoglycemia and about 42% had pre-diabetes. So let's now only focus on those people with pre-diabetes. And what you will see is the nutritional therapies of the people who had pre-diabetes, 37% of them became normoglycemic. Okay? 59% of them remained in the pre-diabetes state, and maybe 3% of them went on to develop diabetes. But it does show you that those 37% of people who went from pre-diabetes to normoglycemia, they had a health benefit from our nutritional therapy. It means not everybody responded, but there are responders in that setting. But we need to be humble, and we need to say that not everybody responds, not everybody has benefits, but we can measure it. If the benefits are there, we continue. If the benefits are not there, we need to change. So let me conclude and suggest to you, obesity is a complex and chronic disease, probably of the subcortical areas of the brain. The health economic benefits are driven by health gains, and prevention of diabetes and diabetes complications such as cardiovascular disease is really what drives the health economic benefits. So the reason why your government is going to pay ultimately for treatments such as tirzepatide or such as semaglutide is not because of the glycemic benefit or because of the weight benefit. It's because these drugs make patients healthier. It's health gain drugs, not weight loss drugs or not glucose-reducing drugs. So the budget impact is a major challenge because very few patients are currently being treated, in this way. So if we are proposing a weight-centric view for people with type 2 diabetes, I think we need to understand it's going to take time. We understand that it's challenging, but we also understand that scientifically it's the right thing to do. So thank you very much for this opportunity.